Dear colleagues, I'm honored to speak here at the Oertli booth. We are looking at the high-frequency deep sclerotomy and the early postoperative results. When we just looked first at the treatment concept. So far, this has been, at least in Germany, the old treatment concept. We go from single medication to multi-medication, maybe SLT, and then jumped very quickly to trabeculectomy and even bigger surgeries like drainage implants. Of course, this all changed over the last couple of years because obviously we want a high efficacy, but we want to have a good safety profile. And in this space, the MIGS procedures, the micro-incision glaucoma surgery, pops up and allowed us to do this. And so all this fades away, and we are moving very quickly from single medication to the MIGS devices, either going through Slem's canal, suprachoroidal or subconjunctival, and push the trabeculectomy to the very last resort. We all know what we can see is the single and multi-medication. The multi-medication nearly disappears in this space because all we know is especially the third drop has a very, very low efficacy for most patients. So we are very fast at jumping at small surgery to relieve the patient. And in this space, there's somewhere the high-frequency deep sclerotomy. And it's a very special operation because we have all these new devices that are popping up every few months, but this is one of the dinosaurs existing for over 20 years in this space, even before the name MIGS was invented or came up. HFDS improves the physiological outflow through the trabecular meshwork, and the device looks like that and is attached to every Oertli device. This very tip is pushed into the trabecular meshwork and uses high frequency power to put small pockets into the trabecular meshwork, and hence improving the outflow directly to the Slem's canal. You can see we're going from temporal to the nasal space, just like with a lot of other MIGS devices, and can be visualized directly. All in all, it goes very fast, so we just go into the trabecular meshwork, push the foot down for nearly 3 seconds, and you have this hole. The great advantage, because you're not using a knife or anything like that, and with knives we all know it could bleed and patients complain for a couple of days. As you're using power to put these holes in, bleeding is not very often with these patients, especially in the first couple of days. So it's very good in the first couple of days. Patients can have perfect vision normally after 1 or 2 days and tolerate this procedure very well. You can even see the result directly after the operation using anterior segment OCT, where you have this pocket inside the trabecular meshwork. And as this is not a new device where we hope for good results, we already have those results. This is a study published in 2011, and patients were followed up over 6 years, and we can see it started at mean 25 and lowered it down to a mean 15, and kept that over a quite long period. And this was confirmed by other studies as well. Here we can see that the side effects are very rare with this operation. Here's a study, a more recent study from 2019, and we can see here, obviously follow-up is not as long, but we can see that over these 9 months the intraocular pressure was quite stable and lowered down to a good level. However, and this is maybe a problem because it's an old operation in the MIGS sphere, there are no real comparisons with other MIGS procedures. And so we do not really know, is it better, is it worse, how does it compare? And that's something we wanted to look into, because over the last couple of years we've done in our clinic a lot of MIGS procedures and hence have a lot of data where we can compare it to. So we tried to compare it with a very well-established procedure where we all know that it works and has very reliable results. So we compared it with the iStent inject. And we did something very important. We did not use any patients where we combined it with cataract surgery. We all know that cataract surgery lowers the intraocular pressure by 10 to 15%, and this is a big confounding factor when we mix these two together. So we, in both groups, we only used patients where it was the only operation, so either HDFS or iStent inject, but nothing else, and compared those two. We took 50 patients and we age matched them for the preoperative intraocular pressure and the preoperative eye drop medication to have nearly similar groups in the beginning. And we looked only at the early postoperative phase, because we know from the older studies it stays nearly the same over a couple of years. So we wanted to see how is it, especially after the first month, because the first month might be a bit fluctuating, but after that it should remain quite stable. So we looked for the first 2 months postoperatively. And in the iStent inject, we all know it lowers the intraocular pressure. We can see went down by 2.6. Even the eye drops were lowered for these patients. When we looked at the HFDS results, we can see intraocular pressure went down significantly by 6.3, so a bit more, but it's crucial to notice that the eye drops stayed the same. Obviously, our referring doctors can decide where they want to see the intraocular pressure and can decide if the patient should take more eye drops or not. But at least we can see, if when we compare both, HFDS is at least non-inferior to iStent inject in the end result. Very important, no serious complications were recorded in both groups, which is very important. And HFDS is a safe procedure. That's quite easy to learn. The target IOP can be expected in the range of 15 to 18. So if you want to go lower than that, then it's not the ideal operation, but we all know that all MIGS are trying to reach into this space, try to at least lower the eye drops that are used. And so far our study indicates that HFDS is non-inferior to iStent inject, which is an established procedure. What we're doing now is we want to see how does this go on. So far we have 2 months. We are now looking at the data over 6 months, 12 months. Does it stay the same? How do the intraocular agents, the eye drops, change over that time? And of course we are adding more patients just to see if these initial results stay the same. Thank you so much.
Thank you so much, Robert. One question directly after your speech. How big was the learning curve for you to work with HFDS compared to iStent?
Yeah, that's very important. I've seen that Eardley recently introduced this artificial eye to train the whole operation. For us, as we were using iStent in Czech before, the learning curve was very low. So basically, it's the same operation with the big advantage with iStent. You can lose the iStent in the anterior chamber. It doesn't stick to it. That doesn't happen with HFDS, so it's a bit easier. And if you're used to do these kind of operations, you do not really need to watch a YouTube video. You can just directly start without any help from anyone, but the artificial eye obviously helps to, if you're not done this operation before, to be quicker at doing it. But for us, the learning curve was very straightforward.